He's going to speak about the multiligamentous injury, timing of repair, and the management protocol. As such, multiligamentous injury is going to be very complex, and the management protocol itself is confusing, depends on the patient when they're presenting to us. And Professor Leonard is going to throw some light on how to manage these complex patients at the right time and the right way. Thank you.
Okay. Much has been talked about the technique and the grafts used, tunnels made. Excuse me. My talk this afternoon is going to be a bird's eye view of what is multiligament and how you approach it. By definition, multiligament means involvement of two or more ligaments. But what is mandatory is either the ACL, one of the core ligaments, either the ACL or the PCL has to be involved, in addition to either one of the peripheral ligaments, the MCL or the LCL. And you can also have involvement of the PLC or the PMC. You also need to differentiate between multiligament injuries and KDs, knee dislocations. Knee dislocation is a situation where both the cruciates, both the core ligaments must be torn, in addition to your MCL or LCL, which should be grade 3. Because oftentimes, multiligament knee injury is a result of knee dislocation, but not necessarily in all cases. So how does it occur? In young, fit and well young people, it happens in high energy collisions like motor vehicle accidents, and usually the BMI is less than 35 or 40. Football injuries can cause multiligament injuries without knee dislocation, and also running injuries. However, MLKIs can happen in obese people, morbidly obese people, by just slipping off the curb, and also in violent twisting and turning dancing situations. I hope this video works. This is a patient who presented to us in our outpatients. I didn't want to. Who presented to us in our outpatients. He is a 19-year-old boy. Look at the guy. Check the guy in the gray dress. Just keep an eye on his left knee, left leg. He's actually leading the pack. There he takes off. Actually, until 80 meters, he's leading the pack, and just about when he's just about to finish, he has a hamstring pull, and then he lands awkwardly. And look at the left knee. Look at that varus force that creates. And this guy had a ACL, MCL, and PLC. So that's what running injuries can do. As I said earlier, oftentimes it occurs with knee dislocation, so you are obligated to go through the full VAC. You must check out the vascular status of all multiligament injuries as a rule. There's no substitute to thorough clinical history and examination. Vascular status, if the ABI is less than 0.9, then the patient ought to have an angiogram. X-rays obviously will help in chronic cases, like we saw earlier in LCL tears, where you can, if the difference is more than 2 millimeters, it's significant. And CT, MRI, and Doppler scans are really priceless in evaluating a MLKI. So what are the options? Conservative, yes, there is still a role. Not all multiligaments need to be operated. But the downside is, the upside is, if you do not operate, they will have a painless, stable, stiff knee. The surgical options are either you repair or reconstruct it. You got to choose your patient. You don't want to be operating on somebody who's got a high BMI with no motivation for rehab, who has medical comorbidities, who's a diabetic, or has cardiac issues at the age of 42. So age matters, the pre-injury activity level matters, and whether the patient has comorbidities or not, and whether the most important thing is a rehab patient should be motivated for rehab. And if the patient says, I do not want to go through all this, you're much better off doing the least. Probably just the core ligaments and leaving the patient well alone. And also, you need to be very careful. For example, that guy who came to our department, he had the ACL, the MCL, and the PLC done, but he wanted to run high level. I said, you cannot. It's such a devastating injury. It's a career-ending injury. So expectations, you need to lay down the expectations right from day one. And Roshan, you think Rob Laprado got this guy back 100 meters? I don't think so, honestly, because it's such a devastating injury. It causes a hell of a lot of damage to the structures in and around. Still, there is no consensus because the incidence of MLKI is only 0.02. So there's no large series, there is no study which comes and tells us this is what you need to do. Timing is still debatable. However, timing depends on the ligaments injured, the vascular status of the limb, and whether there's stability on reduction, and once again, overall health status of the patient is the key. So surgical repair. The recommended time is 3 weeks, max 4 weeks. If you want to do a primary repair, the best time is within 3 weeks, max 4 weeks. At this time, you can do the cruciates at low pressure arthroscopy, which means without a pump, but still there could be extravasation. And when you're doing the PLC or the PMC, it's easy to find the landmarks, but the surgeon, although you take up the patient for repair, as Dr. Roshan Wade said, you must be prepared to augment or reconstruct as the case would demand. As I said, the disadvantages in early repair arthroscopically, you could still have extravasation of fluid, and you could end up, the patient could end up with arthrofibrosis. Now, regardless of what workup you have done in terms of CT, MRI, everything, your final decision on the table should be decided by an EUA, which is very, very important. Surgical reconstruction, after 4 weeks, it's surgical reconstruction. The advantages are, you rest the limb, the swelling comes down, the capsule heals, the collateral ligaments also heal. Sometimes the MCL, most of the times, the MCL, unless it's not a stena lesion, it tends to heal, and so you can save the patient a surgery, really, and also increases the range of motion when you reconstruct at a later date. Mind you, it is not a simple ACL or a PCL surgery. It's MLKS or really complex injuries. So thorough pre-op evaluation, you got to have a game plan, and also you must be prepared to have alternative plans so that you can alter it as you go along once you have the patient on the table. Rehab is the key, actually. You must have a proper rehab protocol, and the most important thing is the surgical team should be aware of what we're doing so that it makes life easy and also reduces the operating time and exposure time. What are the graft options? Autograft, hamstrings, BTB, quads, and peroneus longus. In allografts, you have the BTB, the tib band, tib post, in addition to Achilles tendon. The downside of the allograft is it is available. I won't say it's not available. It's available selectively. The high cost and the disease transmission and graft incorporation is always a worry, particularly if you want to do it for young athletic people and expect them to return back to at least the level pre-injury, at least closer to the pre-injury level they were before the injury. That's why I tend to do the living donor allograft. This guy, he's the runner whom you saw the video, 19-year-old guy, son of a coolie from tea estate in Ooty. So his dad was only 43, got the dad to come down. I knocked off both his hamstrings. And I caused the least morbidity to this guy as much as I can. Synthetic grafts, do they have a role? Yes. Traditionally, synthetic grafts have got a very, very bad reputation. But there is this one graft which is coming up, which is called the neoligament. It has proved the test of time. It has been in practice in the UK for over 15 years. They've got about 15 years results. They are coming to India shortly, and this can be, it is used in 2 centers in the UK, which I have visited myself. They use it extensively for multi-ligament, and hopefully this should help us out when it comes. Right, now there are several algorithms, like the one slide, Dr. Roshan, what I put, it's very cluttered, so I just thought I'll make it very simple. When you have a multi-ligament injury, what you want to do, the take-home message is this: you want to fix the core ligament first, and the peripheral ligaments can wait. If you can do it single stage, you can do it, or if you want to stage it, you're most welcome to do it. And also, you can either do it single stage or 2-stage, and ideally, in the early days, if you can do it, do a reconstruction rather than a repair, that will help, because oftentimes a repair oftentimes ends up with partial reconstruction. So you're better off waiting, reducing the swelling, gaining movement, reconstruct, and do it single or 2-stage. That will be my message for you for MLKI. As I said earlier, rehab is the key. This rehab should be planned even before surgery, and there should be good communication between the therapist and yourself. And on day 1, you must set realistic goals. Tell the patient, look, this is a nasty, devastating injury. You will probably not get back to your original status, but we will have to wait and see as we go along. Do not give any promises. Don't promise the sky. Thank you very much. So it's probably, Leopard is the first time, Roshan? First, and probably this will be the only time he'll come to India. It's a great meeting. If you want to come to Goa, you'll learn a lot. Thank you very much.
Now I request Dr. Ravi Kumaran to felicitate Professor Leonard Ponraj.